right now. We can go to stadiums, we can go out for dinner, there's sporting activities, there's you know, dirt car derbies. It's things are back to what I would say a reasonable level of normality in Queensland. We're not being daft about COVID. You know, we're still sort of, I suppose people like me, it's our job to try and be safe. And, you know, I think we keep pushing the messaging that you're never really out of the woods. With a sort of a pandemic strain of a virus that spreads relatively easy, you know, especially when, like us, we have land borders with New South Wales where there's still transmission of the virus. You're never entirely out of the woods. But we've got good surveillance system in place, and we've got a very robust testing system in place to sort of convince ourselves that at the moment we certainly don't have community transmission in Queensland. So things are, you know, it's hard for me as someone from Ireland who's just recently left to look at home and see the level of restrictions, the level of sort of anxiety around, you know, around circulating COVID. All my friends and family are back there, and it's a really worrying time. And so feel very lucky to be in a state, in a country which I think took some fairly decisive early action to eliminate community spread of COVID. And I'll chat to you a little bit about that. Sorry for the fairly crude diagram. I was saying to the guys earlier that I've been up to my eyes in non-COVID outbreaks all weekend in some fairly high-risk settings. So my time to get fancy slides together has been limited. But the reason I just briefly put this in is because a lot of people, when they're sort of asking about the Australian sort of aggressive suppression model, they sort of think, oh, it's quite easy because it's one country and fairly extraordinarily different endeavor to try and get state by state elimination of community transmission of COVID. And that's because Australia is made up of 8 states, you know, there are 25 million people in the country. And while certainly there are areas that have low population density, there, you know, most of the population live in areas of high population density, you know, like Brisbane and Sydney and Melbourne, Perth. So, you know, the added difficulty here is that what you have is you have these sort of 8 states, and each of them have their own state borders, and they're massive. They're thousands and thousands of kilometers long, and really difficult to police. And they've never been policed before. And each state has its own devolved government and a parliament and a premier and its own chief medical officer and its own health system. And so essentially, you know, while we of course have a federal government, you sort of end up with these sort of 8 semi-autonomous regions who can do what they want. And actually, you know, in terms of health, and we've been quite fortunate actually that pretty much everybody has aligned their COVID strategy, which was fantastically fortunate for us. I'm not going to go into lots of data. I think the bottom line is Queensland doesn't have any community transmission of COVID, and we haven't had a sort of a sporadic case in months. And I think though it's interesting to look at this one single data graph that I've put up here to see that we had a first wave like everyone. So these cases are the cumulative number of cases. So these are your new cases. So what you want to see is a completely flat line to see that you're not getting any new cases. And what you see over on the left, as I'm looking at it, is exactly like everyone had back in March. We had a big wave of COVID, and then we sort of got to April and May, and the line flattened out. And I think it's useful to see. I don't know if you guys can see it because my own face obscures the y-axis on the right with the numbers. But basically, what this graph is showing is that we got up to 1,000 cases sometime in April, and we have yet now in October to reach 1,200 cases. And that, I think, was a really spectacular achievement in a state that is not dissimilar to Ireland. You know, it has the same population roughly. It has, you know, a few big cities and then some regional towns. You know, you've got Brisbane, you've got the Gold Coast, you've got Sunshine Coast, and then you've got your sort of, you've got Cairns and Townsville, which are more like sort of bigger regional cities in Ireland. So not dissimilar, albeit there's some sort of fairly big distances in between some of these population centres, but they're pretty well linked. And there's a lot of travel around Australia. How did Queensland do it? And I suppose, look, you could talk forever on this, but it's after 10 o'clock at night here, and it's a bank holiday Monday in Ireland. So I'm gonna get through it fairly quickly. But I suppose there are probably four main elements to what happened over here. The first one, and the most important one, is border quarantine, sort of mandatory hotel quarantine here. And we'll talk about that in a bit more detail in a moment. There's a very strong public health structure, has been for a long time, much more so than most countries, not just more so than Ireland, but public health has been valued here for a long time. And I suppose one of the reasons for that is that Australia gets hit hard by, you know, whether it's exotic tropical diseases that have a sort of a lot of population health implications, but also over here we get fairly heavily involved in the natural disaster side of things. In Queensland, and I think that's what we do well. Differences between here and in Ireland that are maybe as much about luck as by design in some cases, but we'll have a quick chat about some of that as well. And we've not been afraid to use a legal framework. Australia is a more, despite the reputation, I think, it's been very laid back. Australia is a more rules-based society than Ireland is, and it wasn't unusual during the sort of pandemic response for them to bring in some fairly significant penalties for breaches of the rules around COVID. So I'll have a quick chat about that as well. Border quarantine is probably what we're famous for here. I never thought I'd be saying that. Us in New Zealand, Australia and New Zealand has mandatory hotel quarantine, and what I suppose the thinking behind that is we've always looked at pandemic viruses as being sort of, I suppose, the kind of thing that they're very hard to get rid of when you're constantly seeding new chains of transmission. And we've always thought about it like, I suppose, trying to deal with a flood in your bathroom while the tap is still running. And, you know, our first instinct was to turn off the tap and deal with what's here. And that's really been a very successful strategy. We knew a few things, I suppose, at the beginning. We knew that most of our cases were coming from overseas. We also know Australia gets an enormous amount of travel, and we get a lot of infectious diseases sort of imported into Australia. And we know from decades of experience that travellers are a high risk bunch through no fault of their own. They're often here on a transient basis. So they may not have a GP, they may not have access to healthcare to get a diagnosis. They've been on airplanes, they've been in hotels, they've done lots of socializing, all these sort of risk factors for spread of a virus. So travelers are a high risk bunch, whatever country you're in, one way or the other. And we know that travel seeds multiple chains of transmission, and chains of transmission are a nightmare to get rid of when they're starting from scratch and you're trying to get rid of other chains of transmission. So essentially what the plan here is, and I suppose most people are aware of this, when you come to Australia, you can only get in at the moment if you're a citizen or a permanent resident. When you arrive, you are bused to a hotel, and you're put in your own room for 14 days. And, you know, I suppose the point of that is, we're sort of thinking, well, You may well have COVID, but if you have COVID, we would like to keep it out of the population. So if you develop COVID, we want you to develop COVID in your hotel room, where you're not going to be a threat to the community. So when people go into their hotel rooms, they get monitored pretty regularly for symptoms. And also they get tested on day 3 and somewhere in the region of day sort of 9 or 10. And it's only when your test results come back negative and you're asymptomatic at the end of 14 days that we can let you out. Now we the guys here, the epi guys, really, really good. The modelers have all tried various iterations of the sort of 14-day mandatory hotel quarantine model. Can we do it with 10? Can we do it with 8 days? Can we do it with 6 days if we test people? We test people a little bit more. We just can't. What it seems the best we can get to with a non-14-day quarantine period is that you'll still miss 5 to 10% of cases. And the problem with that is we get a reasonable number of cases coming through, coming through the hotels. And if we were to miss 5 or 10% of them, the problem is society here is now so open that you're not putting a few cases into a sort of a situation where community restrictions are so tight that the conditions don't favor viral spread. I would say the conditions here are pretty favorable for viral spread compared to a lot of countries around the world. So we feel that if we were to do less than 14 days, we would get some cases. And the problem is the whole point of an elimination strategy or an aggressive suppression strategy is that you can open up society. And when society is that open, even letting in small numbers of cases will lead to big outbreaks. So we've stuck with the 14 days. New Zealand's been the same. They haven't come up with a way of reducing those 14 days. And we've been at this for sort of, 9 months. So it's very difficult to see how that will happen. So I think the 14-day mandatory hotel quarantine is here to stay. But, it's a real nuisance for people who are coming home, but it works. It's not easy. It's not pleasant. I just moved over here in January, and we had all sorts of plans to have visitors, and we have a baby on the way, we have Christmas coming up, and we can't have anyone coming over from Ireland. So it's tough, and it's tough on people personally. It's tough on business, but we have no COVID, and that's pretty good. We can go out for dinner, we can go to a show, we can go to a football game, we can do all this stuff that of course we all took for granted. But looking back home, you sort of think, God, how are people coping with months and months of this sort of social isolation? So it's tough, but it works. And I think just the final point on the border quarantine is to note that we also closed state level borders. So initially what happened was all the states closed the borders to close off their own borders to each other. Well, we basically said, let's get rid of what's in everyone's state, and then we'll open up to other states that have got rid of the virus. And that's really where people said, this is impossible, this can't possibly happen. But we did have to police borders, and the police services did a great job of doing that. But I think it's important to note that we certainly we're very cognizant of people's livelihoods and of the effects of these kind of restrictions on society. And I think there's been a lot of talk about the Northern Ireland, Republic of Ireland border in this context. And the sort of system we employed here was a border bubble system, where we were very aware that people who lived in northern New South Wales, for example, might work 10 minutes across the border into Queensland. And so we established these border bubbles where if you live, and the size of them has changed over time depending on the situation in other states. But essentially, if you live within, 20 or so kilometers from the Queensland border, you could cross to do your job in Queensland, you know, but there was a lot of documentation involved, and you can only come over for the purposes of your job and that kind of thing. And you could cross over for essential healthcare and stuff like that. So we don't entirely shut the borders off, and we give exemptions for people who want to visit different states for sort of you know, for reasons like visiting dying relatives and stuff like that. So it's been a pretty well run system, and it's been I think it's been a relatively compassionate system within a sort of a setup that is by its nature a little bit uncompassionate. So yeah, borders both sort of international and state level have been successful. Most of the internal borders are open up now, but I think it'll be a little while before the international borders open up. But of course, the plan when you're dealing with an elimination thing is not to sit around for, you know, for 2 years with your borders shut. It's to find other countries that have eliminated the virus as well and open up to them. And hopefully we'll all be able to travel to New Zealand soon, and with a bit of luck to parts of Southern Asia in the coming months too. Strong public health measures, I think, are really important. And I think, I suppose this, what I'm talking about now is, you know, your border controls will stop the importation of new cases. And if you do it properly, now remember there's a big operational element to that. And it's not easy to do, and it has to be done well. But if it's done well, you will stop cases coming into the country as we did. And we've had some sort of high profile failures, and so have New Zealand, but certainly learned a lot from them, and they're few and far between now. But you can't just stop cases getting in and not expect the cases that are already within the country to spread. And that's where I think you've got to stop the cases coming in, and then you've got to get rid of what you already have. And to do that, you need a very strong public health system. Australia's been really good in their pandemic planning. We've been close enough to things like SARS-1 to be worried about it. Pandemics, I think in Western Europe, my feeling has always been pandemics have been a little bit far away. You know, that there's something that probably won't happen, you know, but in Australia, that's never really, that's never been within the psyche. Pandemic planning is strong here. And back to when I was a registrar here in public health, you know, 10 years ago, it was always the same. We were always planning for the next pandemic. And we weren't just assuming it was going to be the flu, like the few countries in Europe who seemed to plan for pandemics seemed to think it was going to be the flu. We had very strong pandemic planning. You know, so I think that's a major difference between Australia and a lot of other countries. A lot of people talk about Australia and New Zealand and talk about the difference in their response and base it purely on geography, but the difference was based on preparation as well. You need a good public health workforce plan, and I think that's where Ireland really sadly falls down. You know, we have never had good public health in Ireland. Like I said, in Australia, they sort of value the fact that we solve problems that just never, in Ireland, I don't think public health has ever been able to get a seat at the table. And I think for the benefit of people who are not familiar with how public health works in Ireland, there's a lot of chat within Irish media, and you know, about they sort of equate public health to being test, trace, isolate, or contact tracing, or whatever, when that's nowhere near the truth. And it's contact tracing is about, you know, it's about 25% of what you do when you're managing an outbreak or something like that. You know, contact tracing is asking somebody where they've been and who they've been with, and ringing those people and telling them to self-isolate. That's an important part of it, but there's much more to it that requires specialist public health doctors, specialist public health nurses, surveillance scientists, epidemiologists, and the whole lot. And I suppose that's probably where we fall down in Ireland, and we're probably paying for that now. There's lots of talk about hiring an extra 1,000 contact tracers. But unfortunately, what you need in Ireland is you need to staff. There's 8 regional public health units in the country, which have a sort of a handful of absolutely overwhelmed public health doctors, which is only about 40 in the country, trying to manage 1,000 plus cases a day. I mean, and it's not just their cases, it's their 10 contacts each. It's a ridiculous amount of work for people to undertake. And I suppose what's the most remarkable piece of the story, to my mind, and it's not an industrial relations point I'm trying to make, is that Ireland can't get public health doctors who sort of run these public health units, who run the outbreak management side of things. And there's this bizarre historical anomaly in Ireland where when you train as a consultant in cardiology or neurology or pediatrics or whatever it is, the HSE give you a consultant contract, which gives you the autonomy you need to do your job, gives you a team, gives you the authority you need to do your job. In Ireland, public health medicine is the only specialty. When you get to the end of your consultant training, they say, well, we're not going to hire you as a consultant. And while people think that's sort of a HR issue, what it means is you don't have the authority to do your job, essentially, and you can't do your job to the best of your ability. And what it means for Ireland right now is that we've hemorrhaged public health medicine consultants. So people like me work as consultants in Australia. The UK gives you a consultant contract. Every English-speaking country in the world does that. And unfortunately, they own all of the Irish public health doctors at the moment. There's very few of them left, and it becomes a very unattractive specialty for young people. And successive health ministers have said that needs to change urgently, and successive government reports have said that it needs to change urgently. And we all know that the wheels turn slowly on this kind of stuff, but it's remarkable that we're 9 months into a pandemic and Ireland has yet to employ a single solitary public health medicine consultant. It's extraordinary, and I suppose that's the sort of issue you're talking about with your public health workforce. Lots of issues with the nurses, the surveillance scientists as well. It's not been well planned out, it's not been well resourced, and it becomes very attractive for skilled people to work in that service. And to be honest with you, the ability to manage an outbreak is a very niche skill. Not many people have it, and it's one of the most in-demand skills globally now. So Ireland definitely needs to step up its game in that space. And another thing that's different here, and that I've really liked actually, is that the public health units are integrated within the hospital groups. So I'm part of a hospital here, and there are lots of, aside from just the benefits of knowing all my other consultant colleagues in the other specialties, and they get in touch with me more, they talk to me more, I'm more on top of what's happening in the hospital. There's also, I have those resources to call upon. So when we have an outbreak, or when we had outbreaks of COVID, if we wanted to rapidly step up some testing centers, I could speak to the operations officer in the hospital and say, have you got any nurses that are available today who could do some swabbing for us? And they'd say, yeah, you can have them. When we were getting swamped and I needed a registrar, I went to the hospital and said, is there a junior doctor who might be good at this type of work? And they said, yeah, here, we'll give you somebody. I think that's been a real benefit, the sort of integrated nature of public health and the sort of the hospital system in Australia. I think Ireland could learn from that. And I think finally, in terms of the public health response, we are relentless here when dealing with COVID. We've kept our cases low, but we've also aimed to keep them low. And I think that's something that I think there has to be a relentlessness to your approach to COVID. I've heard lots of countries talking about we isolate 70, 80, 85% of contacts of cases. And I think, God, we'd be doing pretty much 100% here. We wouldn't let a contact through our fingers, not because we're any better at it, but just because we are much more relentless. We regard each contact of a case as being a potential, as being the beginning of a new transmission chain. And we're absolutely relentless. And we give cases, and we give their contacts legally binding quarantine notices to stay indoors. Now we give them a lot of support with that. We don't just sort of dump them indoors and say see you in 14 days. We're pretty good at helping them with that. But I'll talk to you a bit more about that when I talk about the legal side of things. But I suppose to summarize the public health piece is that we're well resourced, we're trusted, we're given the autonomy to run our own local, our own regional outbreaks. We just get on with it. But we have loads of support. We have a sort of a communicable diseases branch, a headquarters in Brisbane, who are extraordinarily helpful and offer us some support if we get overwhelmed, and they coordinate help. If my unit, for example, got overwhelmed in a massive outbreak, they would get the other units to help us with staff, to do some contact tracing, to do some outbreak control, outbreak investigation. So we're given a lot of autonomy, but we're given a lot of support as well to help with that. It's a really coordinated system, really, really nice system to work with. I'll talk briefly about testing. You know, I've always thought that testing in Ireland, the criteria are much too narrow. You know, you're going to miss cases with the criteria as they are. Having to go to a GP, you know, who then has to book an appointment, and then the testing people ring you or send you an SMS and tell you have to be at this place exactly tomorrow, you know, at 12 o'clock or whatever, and it might be 2 buses away. The problem with that is that that's fine for me or most people, but vulnerable populations don't engage with that type of sort of appointment-based, sort of multi-stepped approach. We know that from years and years of public health. So the criteria are too narrow, and the sort of difficulty, although we may not perceive the difficulties being great, from a vulnerable population perspective, which COVID loves vulnerable populations. From their perspective, it's, you know, it's a difficult process to navigate. But I mean, that's obviously secondary to the fact that testing capacity is limited, and I don't think that's anything that Ireland is uniquely bad at resourcing testing. I think there's the type of people who do lab testing have master's degrees, the whole lot. Like they're not easy people to just pluck out of thin air. Even lab reagents, the machines to do all this stuff is at a global premium. So how did we do it? We've done very well with testing. Well, we had a long history in Australia of using the private sector much more than Ireland does, and the private sector loved ramping up when there was a demand for testing. They had very sophisticated sort of supply chain networks, and you know, they were very, very good at it. So we used the private sector. In fact, if you go for a blood test in Australia that your GP sends you for, chances are you will be going to a private sector lab. So there was lots of different providers who were able to ramp up their production. So we weren't relying on one central, you know, government lab, if you will. We had lots of people working on their own capacity. So we have sort of 3 or 4 companies who'll do COVID testing, as well as the government labs. So we have a strong private sector. We have these walk-in on-demand fever clinics. So we just tell you to, because we have that capacity, you know, our message is, if you're sick in any way with anything resembling a cold or a flu or a head cold, no matter how mild your symptoms are, come along and we'll test you. And I'll show you some pictures of these fever clinics in a moment. We have rapid testing for high-risk situations. So if we have an outbreak in a nursing home, we'll go in with rapid PCR testing, these sort of gene expert tests where we can have a result back in 2 hours. So we can test, you know, all the residents of a nursing home very, very quickly in the case of an outbreak. And that works pretty well, notwithstanding all the issues around rapid testing, but targeted rapid testing to high prevalence settings works pretty well. And we also have rapid response sort of testing and swabbing teams. So the private sector, again, you know, lots of people have strong opinions, often negative, of the private sector's involvement in healthcare and this sort of urgent pandemic response that they've not traditionally been a big part of, but actually they've been a a sort of a welcome partners in this response. So, for example, some of the companies, if you have an outbreak in a nursing home or somewhere high risk like that, they will send a team of nurses in there, full PPE, the whole lot. They will swab everyone in there. They'll bring it to their own lab. They'll run their own PCR testing, and they will give you the results back on a spreadsheet the next day or later on that day. So we've some pretty sort of slick private sector solutions going on here, but you know, Ireland doesn't really have that sort of level of private sector laboratory testing, and I suppose it's not something you can just ramp up overnight. This is something that's been happening for decades in Australia. Here's our local fever clinic. I took this photo this morning, beautifully empty actually, and actually that's one of your problems when you get to really low levels of COVID. I was on the radio here this morning asking people to get tested because our testing rates are falling, and you know, the only way you can be sure you don't have COVID is if you're testing enough people to be sure you don't have COVID in the area. But actually our testing numbers are dropping, as you would expect. I don't think any country, when they get to really, really low levels of COVID, has people rushing to get tested. Our testing, like everywhere else, is sort of, it's a function of people's worry and their panic. And when something comes into the media, they come and get tested. Nonetheless, this was at about 7:30 this morning, so it was just opened. We still, you know, where I live, we're testing hundreds of people through these clinics. So, but essentially, this is a great example of there's a really strong disaster management setup in Australia, and particularly in Queensland, because we get so many natural disasters. And this is a great example of it, because I was able to say to the hospital that we needed fever clinics, as we call them, and we needed some nurses from the hospital to be trained up to do this. So the hospital were able to sort that out. They were able to supply these marquees, the testing equipment, the whole lot. Then we went to our sort of local disaster management group. Each region in Australia has a local disaster management group, which feeds into district disaster management groups, fairly sophisticated disaster management setup. And within one meeting, we said, this is a county council car park. And we were able to walk into a meeting and say, look, we've got nurses, we've got tents, we have equipment, and we just don't have anywhere to put them. And the disaster management group say, okay, yeah, we'll give you a local council car park and we'll clear that out. So that was a public council car park, and they just cleared it out next day and gave it to us, and we put the tents in. So we had a fever clinic up and running within the space of about 2 days at the beginning of this thing. You know, it's all about that multidisciplinary approach, that sort of disaster management approach, which has always been a part of the sort of the Australian sort of public health psyche, and it's worked really, really well for us. And anyone could turn up there for free testing for any symptom that they're worried about. They can come for testing. We have a legal framework. The Australians have not been afraid to jump in to enforce sort of the guidelines. Now, I would say I'm a fan of this, and I think people are going to think that I'm some authoritarian public health physician who just loves to fine people. I absolutely despair when people talk about the use of legal solutions to medical problems. I'm against all sorts of things like mandatory vaccinations, stuff that where we make people do things. I'm all for bringing people with us, not dragging them with us. Having said that, the reality of a pandemic is that we have to think about the safety of our most vulnerable citizens, and there will always be a cohort of people who just will not sort of cooperate, and there's no reason why. I live in an area with a much older sort of median population than most of Australia, and no reason why our elderly citizens who are scared enough at the start of this should be put at risk for people who deliberately breach guidelines. So we have fairly strong fines, and they get enforced, but they tend to be a last resort. And what you find with most people is just that the threat of a fine is well enough. But on the flip side of that, there's good support so people who are financially impacted, similar to the pandemic unemployment payment in Ireland. We have lots of things and lots of supports for businesses and that kind of thing. So, we're not just taking money away from people. There's lots of money in supports and subsidies being given. And like I said, enforcement is the exception. What I really like is the quarantine orders. I think when you're dealing with a tsunami of cases like Ireland is, the idea that you have cases and you have close contacts of them and you're advising them to stay indoors, and they don't have to if they don't want to, and there'll be no consequences. We know from public health history that probably at best we only ever get about a 70% compliance with sort of things that are a big ask, and quarantining yourself is a big ask. And so we issue if you're identified as a close contact of a case, you'll be given a self-quarantine direction that's legally binding, and the police will do spot checks on you. They'll turn up at your house unannounced and make sure that you're there. So it's a tough regime, but what I would say is we're tougher than Ireland, but we're way more supportive as well. We will, in the public health units, we'll have a list of all the people in our region in quarantine, and we'll ring them every day. We'll make sure they can get their shopping. If they can't, we can contact the Red Cross. We'll go out and help them. If they have a sore back, we'll have a chat to their GP and see if they can do a home visit. If they can't, we'll do a risk assessment to see if they can go and see their GP under the appropriate conditions. If they can't, we'll get a doctor from the hospital or from an out of hours GP. So we'll sort something out. We'll get them managed. If they have mental health problems, we'll sort them out with counselling over the phone. If they have substance addiction problems, we'll get them what's called an AODS doctor here, alcohol and other drugs, doctor to support them with that. We've dealt with everything with people in quarantine, and we've managed it. And actually, it's another one of the great things of our public health unit being integrated into the hospital. If one of them has a problem, they've been seen a specialist. I can ring their consultant and say, look, Joe Bloggs is out here, he's one of yours. Could you give him a call about this? Because I don't want him going to his GP if he doesn't need to. We're very supportive. We come up with lots of solutions, and so we are strict, but we're very, very supportive. Towards the people who end up in this unfortunate situation. So yeah, we use the law. In principle, I don't like it in public health, but I think it's been useful for us in this situation. And look, just here's some of it. I don't, again, on my screen, my face and Tricia's face are in the center of the screen, so it's getting in the way of what I can see. So I'm not sure if that's the same for you guys. But look, you don't need the details of this. This is just one example of the menu of fines that are available in Queensland for people who breach orders, and you can see they don't mess around. They fine you. They have penalty units in Australia, and each crime is worth a certain amount of penalty units, depending on how severe it is, and they tend to be 10 for most of this COVID stuff, which is about $1,300, which is about €750, and it will be enforced. And Australia is a bit more of a rules-based society. It's not as much of a big thing here. People expect that if you don't sort of adhere to these guidelines, you'll get fined. But like I said, that's actually not the norm. The threat of it is usually enough. It's higher for businesses, bars and restaurants and stuff like that who don't adhere to their guidelines. They're up to 6,000 plus, which is about €4,000. So they're not small fines, but we don't have to use them very often. Been quite a while since I've heard of one being implemented here. But if they're needed, they will, for sure. So I suppose the final slide here is just a question. People often say to me, well, Australia is one thing. Can Ireland achieve elimination? And what I would say is there's two elements to that question. From a public health communicable diseases perspective, there's no question that you can achieve elimination. I've never met a public health doctor who didn't think you can't eliminate a pandemic virus from inside a closed system. So if you shut off your borders or impose mandatory quarantine, you're left with just the virus that's within that's within those borders. And of course, if you aggressively chase down the virus, if you aggressively chase down the close contacts, if you aggressively prevent and manage outbreaks, of course you can get rid of any virus that when you don't have new cases coming in. So, you know, nobody can say that it's impossible to aggressively suppress or eliminate the virus, whatever you want to call it. Essentially, what we mean is get to a stage where you don't have any sporadic cases, when you don't have any sort of unknown community transmission. And what that means in real life is that nobody's turning up to a fever clinic or to their GP or to the hospital with symptoms and, you know, getting swabbed and being diagnosed with COVID and sort of saying, I've no idea where I got that from. That's what we're looking for. We don't want those unknown cases or mystery cases, as they get called over here. And so you can do that. There's no question. From a technical communicable diseases disease control perspective, you can do that 100%. There's no issue with that, and I don't think anybody would tell you differently who has you know, managed outbreaks for, you know, in their career. I think nobody would tell you different. The issue is, of course, all the other stuff that goes with it is the political stuff, and you know, that's where you know, I suppose can it be achieved? Well, it depends on the politicians, really. I suppose that's the reality of it. I guess we're told, and you know, not being based in Ireland anymore, I'm loath to try and tell people in another jurisdiction what to do, but I suppose I keep hearing that the politicians won't have it, you know, border quarantine, and that the people you know, within border counties won't have it. And I get that under normal circumstances. People often say that I'm naive to think that we should talk to these people, but I suppose you would have to think that whether you were to do your border as an all-island thing, so have your mandatory quarantine on your way onto the island of Ireland, or whether it was have your mandatory quarantine on your way into the Republic of Ireland, you need mandatory quarantine for 14 days to achieve elimination, to my mind. Whether your border is drawn at the border between the Republic and Northern Ireland, or whether it's, you know, drawn around the island of Ireland, some people, you know, ideologically will not be happy with that. But you would have to imagine, given the level of societal restrictions and the level of hospitalizations and the fear amongst the community, that this would be the time to have that discussion. And I suppose I haven't seen any real evidence of that sort of civil society level sort of discussion happening to see, is this something that the communities would tolerate on a temporary basis. And if it is, then I don't think the political objections to it, you know, I don't think that the politicians should be able to say then, well, we don't want it, or we don't think it's practical. So I mean, look, it's a deeply divisive issue. It's a difficult issue, but I can't imagine anyone north or south of the island wants to go on like this for you know, 6 months or a year, because the reality is, if you decide to live with a virus that frankly doesn't want to live with you, you're into recurring lockdowns. That's the reality. And I suppose that's the reality that has to be put to people. Would you like to try and enter some intense negotiations, you know, with our friends in the UK and Northern Ireland, and see if we can come to a solution? You know, can we talk about this? Or is it, because it seems to have just been off the table right from the beginning. But I mean, you've got 1,000 cases per day in the Republic, and you've got probably the same in Northern Ireland. I mean, these are insane levels of disease, and they'll come down when you have lockdown, and they'll stay down for a little while, and then they'll come back up, and you have another lockdown, and they come back down again. Like, surely now is the time to have that chat and just say, and look, if everybody says no, we would rather let COVID run free than you know, cooperate on borders, fine, okay, you know, you've tried. But it just looks to me, looking from afar, and worrying about my own friends and family at home, it just doesn't look to me like anyone's really put this forward as a viable solution. Maybe it's all happening behind the scenes. I don't know, but I think it would really benefit from some good quality modeling, a proper feasibility study looking at the legal implications, the sort of public health implications, the sort of the geopolitical implications, civil society implications. So that's all I would say. I'm not elected to run any country, and I wouldn't do Stephen Donnelly or Tony Hullen's job for all the money in the world. And extraordinarily difficult position to be in, but you would have to think that this option doesn't seem to have been pursued to the point where you would say it can't be pursued any further. And honestly, like the last thing I would say is that it's tough, and it would need a lot of negotiation, and operationally it's difficult, and legally it will be difficult. But life's good here at the minute in Queensland. It's a bit hot. Life is almost back to normal, and I just don't understand if people are going to live like they are in Europe for the next 6 months or a year, however long it takes to get sort of herd immunity through vaccination. So yeah, look, here's hoping for you guys. But look, that's probably all I'm going to say on any of this. I've probably gone on a bit longer than I had anticipated, so my apologies for that. Happy to take any questions, or I can just finish up there. Trish, whatever you, as the boss moderator, feel yourself, I'm very happy to go with.
Well, first to say thank you, Niall. That was absolutely fantastic and great, I think, in the depths of lockdown in Ireland, to see that this can be done, and that scientifically, that it is possible, and completely agree. I think within the Independent Scientific Advocacy Group, ISAG COVID, one of the things that we've been really trying to argue is that the science is there, and what we really need to open up now is the conversation within society about the types of choices that we're making. And it's been, I think, really helpful for us to see how operationally and technically that's been done in Australia, where you have issues like we do with borders. So that's really helpful. We have had a couple of questions that have come in on the chat function and the Q&A. So I might just, if you have time, I know that it's very late at night and you've already done a very busy weekend. So one of the questions that's come through is around the fact, and you mentioned this, that historically our public health system in Ireland is under-resourced and is definitely overstretched at present, and working extraordinarily hard to try and do the best they can. But given that we can't really fix that overnight, one of the questions is what are the most important things, 3 important things that we could do here in Ireland to eliminate community transmission?
Well, the one important thing is to implement some form of mandatory border quarantine. There's no other way, to my mind. And look, it's just one opinion, but it's backed up by some real world experience that I don't think you need to do 3 things to eliminate community transmission. You just need to do one, and that's mandatory border quarantine. Now, like I said, you can't do that in isolation. You need to aggressively hunt down cases, and how long that all takes depends on your starting point. If you bring in mandatory border quarantine when you're at 50 cases a day, you'll do it fairly quickly. If you bring it in when you're at 2,000 cases a day, it'll take you longer. So that's you can't do it without mandatory hotel quarantine. I've not seen that happen anywhere. It's not happened anywhere, and I don't know how you would. After that, it's all about hunting down your cases, and it's about getting them tested and finding them and traced and the whole lot. So it will be difficult to do, but if you got your case numbers low enough with mandatory hotel quarantine or mandatory border quarantine, the public health units could cope at that stage, and they would be, them along with the contact tracing centres would be able to get the cases down to sort of ultimately to eliminate community transmission. Granted, it would take a little longer in Ireland because the structures are not necessarily in place, but yeah, mandatory sort of border quarantine is the one thing you need to do before you do any of that.
Okay, that's really helpful. Thanks, Niall. From a kind of a practical perspective, in terms of staff working in transport, like ship staff, pilots, commercial airline staff, how is that managed?
You've a few examples there, and to be honest, it depends on the example. So we have some pretty detailed and sophisticated industry-specific plans, as we call them. Everything from fruit picking to international travel to the maritime industry, and we have big working groups within the ministries responsible for those industries, and we come up with a plan, based on the industry. So for example, pilots and air crew who are coming in and turning around pretty quickly don't have to get tested every time they come in. If they're just gone, they get brought to a hotel room the next day, might get brought to another plane to be, they're not going to be flying it the next day, but they might be flown home. And we're not testing those people every few days. We have industry plans for them. But like if you're on a maritime vessel and you want to come abroad, or you want to come aboard in Australia, you'll have to do mandatory quarantine. If you were a cabin crew coming back and you wanted to stay for a long time in Australia, you would have to do mandatory hotel quarantine. But we have lots of industry specific plans, just as we have internally as well. So when we had all the restrictions, and we still have the restrictions with Victoria and Melbourne, the country can't function without lots of essential services. So, you've got truck drivers and stuff who we have various testing regimes and, various plans that they can drive down to Melbourne, but they can't get out of their truck when they arrive. Another team has to come and empty the lorry, and then they just have to turn back around, and that kind of thing. But they're fairly complicated regimes depending on the industry. But they're all well documented, and the industry people are all very familiar with what they need to do within their industry. And there's been a lot of effort put into these sort of industry specific plans, and they're very good and very effective, and actually haven't really had any breakdowns in them. But they are fairly strictly enforced. Yeah.
Okay, great. And then another kind of practical perspective question, in terms of those communities that are living on or across the Victoria-New South Wales border, how in practice is that implemented? I know you mentioned those bubbles.
Yeah, bubbles is the way we did it. And, it was all about border communities. There's lots of border communities in Australia, and they're important communities, and they're in some places big communities, and they were an important part of the strategy early on. And we, like I said, we've just had these bubbles. We accept that people will work across 10 miles up the road, will be in a different state, and people work there, and they have to have a pass, and if there's a checkpoint, they have to show their pass. But I mean, it's a fairly straightforward online process that's not too onerous, and usually what happens in reality is you stick your pass on the dashboard of your car, and you just get waved through. But it's a legal requirement when you cross the border, say from New South Wales into Queensland to come and work. It's a legal requirement that if you get sick, you'll be tested, and if you don't, you get a big fine. So it's made easy for you. That the sort of the sort of border pass that you require is easy to get, and it's made easy. Whatever you need to do tends to be easy, but it's also enforced as well. But border bubbles are very successful, and I'm not aware of us having any cases slip into Queensland because of the border bubbles. They've worked really well, and they also tend to be a little bit more rural. The sort of border bubbles, so they're often not in the sort of the epicenter. The New South Wales border towns are nowhere near Sydney, where they had most of their cases. So the rural nature of these border areas, as it happens, is also beneficial. But we've had no seeding from border bubbles that I'm aware of. So it's worked very effectively.
Great. Another question, I'm sure you'll have been aware with the difficulties that we've faced here with nursing homes, and so one of the questions that has come through is about visitors to long stay facilities and how that has been managed.
Yeah, so I suppose during the first wave that was difficult. We're in a situation like Ireland where we had no visitors to many of them. Now they're very much opened up. There's when you come in now, there's symptom screening, there's temperature monitoring, the whole lot. You have to leave your contact details. You also, interestingly, you cannot legally enter a nursing home in Queensland unless you're vaccinated against the flu. And I mean, no exceptions, unless medically you have been refused the vaccine, you're not allowed go in. And that's been an effort to sort of keep to preserve resources, because we've just come out of winter here, which didn't feel much like a winter, but we just come out of winter when we would normally get lots of flu outbreaks in nursing homes, and we wanted to preserve the sort of public health workforce and not sort of muddy the water. So we brought in this mandatory sort of vaccination for anyone who wants to come in, including also staff and support workers. That's been really good. But yeah, you can visit people in nursing homes now. When occasionally we've had the odd flare up in Queensland, we very quickly, a while ago, there was a sort of a few cases in Brisbane, a bit of an outbreak that had been brought in interstate, and very quickly they declared that region as sort of a bit of a hotspot. And within that region where the case was, you couldn't visit nursing homes until we were sure COVID had left there. But that didn't affect the rest of the state. So we have very strong local enforcement as well, the ability to do that if needed. And I have to say, in Queensland, we've had just a handful of nursing home outbreaks. But our visiting and residents can come and go now. I mean, they are careful, and we have dedicated nursing home teams here who go out, nurses who will visit the nursing homes and just make sure everything is running well from an infection control perspective. We're very involved public health sort of nursing home sort of interactions, and we have a fortnightly, so I run in the public health unit, a fortnightly teleconference with all the nursing homes in my area, where we just chat to them about any issues they're facing, and we do some desktop exercises, that kind of stuff. But to answer the question, visiting, visiting is allowed now in nursing homes, which is fantastic. The real benefit of COVID elimination.
Great, thanks, Niall. I suppose another thing that's been really important and very topical here is schools. And as you'll know, during our first lockdown, all our schools closed, and there's been a huge emphasis on trying to keep our schools open. And I was just wondering whether schools had closed, and we've had a question in about that, whether schools closed in Victoria and how long they closed for.
Yeah, they did. And during the real extreme high levels, where it went up to 800 cases one day, they closed their schools. But I suppose the overriding sort of aim all around Australia has, right from the beginning, been to keep the schools open, and I'm strongly in favour of that. And you know yourself, the theory, of course, is that schools aren't driving this. I know people get vexed when people say it because they're worried about their kids, but when we talk in public health about drivers of transmission, we're not saying that your child has no risk whatsoever being in school and there won't be any cases in schools. What we talk about drivers of transmission is sort of where the increase in cases come from. And to give you an example, every year we see the flu, and what happens with the flu is it gets into communities, and there's little pockets of flu, and then it gets into the local school, and then boom, it explodes into the community. So we know that once flu gets into the school, all the kids bring it home and they spread it. And so we say the flu drives transmission. So we know that schools are a driver of transmission for flu. With COVID, it's sort of the other way around. What you see is, it's sort of, you get pockets of, COVID cases, and you might get the odd case in the school. But once you have lots and lots of it in the community, then it starts getting into the school. So we know that community transmission drives school outbreaks. So schools aren't driving community transmission. So from that perspective, we think then the risk of keeping schools open is not to the community, it's to the individual in the school, so the child who might contract it. and we know that children get less severe disease than adults. So we think it's reasonably, relatively, and everything in a pandemic is relatively safe or relatively unsafe. We think it's relatively safe to keep the schools open, and but to be careful. And primary schools are much safer than secondary schools, of course. So we've kept schools open, and we've even when we had our first wave. But yet Melbourne is the only place that really said it was forced into closing schools, when they had their second wave. And I mean, we did at the beginning close schools for a while when we were trying to work out what was going on. I think everyone was trying to get their head around the epidemiology, but we very quickly opened them, and our aim is to keep them open. And yeah, I'm a big fan of keeping schools open as much as you possibly can, because the effects on children of not being in education are lifelong, and really can't be underestimated.
Yeah, completely agree. Thanks, Niall. A practical question: who pays for the hotel quarantine?
Yeah, very good question. So at the beginning, the government paid. So they would just put you at a hotel and you'd get a bill or anything. What happened was eventually it was very costly, and the government's take in it was, there came a point where they said to everybody, you need to get home to Australia now, or we're going to start charging you for quarantine. And if you had a ticket, they gave people some time, but they sort of had a date, and they said, if you have a ticket home booked before this date, you can have your quarantine for free. If you've booked your ticket after it, you can't. So you had months and months and months to get home to Australia if you're an Australian citizen. Now, a lot of people couldn't get home because you may or may not have seen in the news that lots of the flights were cancelled because there's only a certain amount of people allowed to come into hotel quarantine every week. But if you booked your original ticket before whatever date that the cutoff was, I can't remember when it was, then it's free. If you didn't, then you have to pay for it, and it's about, per couple, it's about $4,000 for the 2 weeks. So that's a little bit less than €2,000. So it's expensive enough.
Thanks, Niall. I'm conscious of your time as well as everybody else.
Oh, you're okay. Yeah.
Do you have time just for a few more questions?
Yeah, fire away. Yeah.
If that's okay. So one of the questions here is around the success of the Australian model. And do you have any insights into how we would get such a strategy adopted and implemented in Ireland and more broadly in Europe?
You just broke up for a second. Can you just repeat the question?
Yeah, sorry. So given the success of the model and approach taken in Australia, how would we go about trying to actually implement it?
I mean, look, the operational side of it is something that's lots of expertise already within Ireland around, and far more than I would have of how to operationalize the whole thing. But like I said, it requires mandatory hotel quarantine for 14 days to my mind, which I suspect the hotel industry would be pretty happy with, actually. They can't be doing particularly well, I'd imagine, back in Ireland. So having lots and lots of people staying for 14 days would make them very pleased. But look, I do think it needs mandatory.
A practical question on that. Did everybody stay in airport hotels, or were they more widely disseminated?
No, it was basically, if the hotel was willing to do it, they could enter a process to apply to be one of these hotels, but you can't do anything else. You can't have your restaurant open, or you can't have your bar open, or stuff like that. So not all hotels want to do it. But yeah, they're often in the city centre, but you get taken off your plane, you get put into a room as a cohort with your flight, you get put on a bus. It's all very socially distant. You get brought to your hotel and put straight into your room, and that's that. So yeah, no, not all hotel rooms at all, or not all airport hotels at all.
Great. And just in terms of the walk-in clinics, the question that's come up here is in terms of the governance of those and the kind of reporting pathway between these fever clinics and the hospital private labs and the public health units.
Yeah, they're great. So the fever clinics, the walk-in fever clinics are under the governance of the local hospital system and their hospital nurses. And like I said, the public health unit is part of the hospital system. So I know all the nurses. And what's brilliant is that we've had several really risky situations cut off straight away by them just picking up the phone to me and saying, Niall, there's someone here who's just presented for testing. I think they're really high risk, and I'm really worried about them. What do you reckon? And I might say, well, let's get them a rapid test actually, and and they've come back positive and been able to jump on top of them really quickly. And actually that whole, so the fever clinics are part of the hospital and they report to the hospital hierarchy, but they work very well with public health because they're used to working. We're very used to working with our hospital colleagues, and these are usually nurses from the hospital. The private labs don't tend to run fever clinics. They tend to run the testing facilities for GPs. So if a GP, if someone comes into their GP with a head cold and the GP tests them, they send it off to a private lab, and it's so well integrated. You wouldn't know the difference between them and the public labs. There's consultant microbiologists in all the private labs, and they all have all of the public health physicians' phone numbers. They'll ring us up. So I'll know before a result. If there's a result in my area, I'll know before it gets even near the computer system. They'll ring me up and literally say, Niall, a test just come off the machine now, and looks like the address is in your region and it's positive. And they'll give me a heads up. Really, really well integrated. I have to say, I've never seen such a well integrated public private system, but it has taken decades to do that. That's been that's very ingrained in the system. It's not something that's happened during the pandemic. It's since I've been involved in Australia back in 2009 and long before that. That sort of integration between public and private has worked well. I'm sure there are problems with it, but it served us well during the pandemic for sure.
Great, thanks, Niall. A question here on universities and how well they have responded.
Industry specific plans. We do this for all of the big industries. Have plans with us, and the universities have been really, really great. Actually, we haven't had really big university clusters. I know I keep hearing about these problems in Ireland, but during our waves, they very quickly went to online learning. But online learning, I worked in UCD for a few years recently, and I don't remember us doing much online learning, but I was doing my master's in public health in Australia in 2008. And in Queensland, we were doing online learning back then. So I don't know if there's a sort of a difference broadly between the universities, but they very quickly went to remote learning. Look, some courses, it was more difficult. Your medical students, your nursing students, radiography, all these kind of things where you require contact with patients, that they were interrupted for a period of time. So we sort of worked out how safe it was for them. But generally, online learning has been the norm. But now classes are back, and people are back on campus. They're socially distanced. And they're, I suppose, like everything, isn't it? It's when your community cases are, when you don't have any community transmission like ours, that the risk is very low. But universities have their own industry plans as a group and stick to them really well. And we haven't had any major problems with the universities anywhere actually in Australia that I can think of, and certainly not in Queensland. So these industry specific plans, I'm a big fan of them because they're specific to your group, and the universities will have been stakeholders in it. And it's a really good system actually. It's worked well. Great,
thanks, Niall. And it sounds like a lot of the longer term work that you've done in terms of pandemic preparedness probably put you in quite a strong position.
Sure, yeah.
A couple of questions have come in about testing and the type of testing that's done, and whether rapid antigen testing is being used.
No, it's not. We can access rapid PCR testing, and PCR testing is the outside of culture. It's your gold standard, and it's if we get an outbreak in a nursing home, I can access rapid testing, rapid PCR testing, very quickly on site, even though I'm not in a big city. So that's what we use here. The problem with common antigen testing is it's just not it's just not as accurate as PCR testing, and that's the difficulty. And so I suppose antigen testing has its role in what I would say is when you've got high pre-test probability symptomatic people, you'll believe a positive test. Then the problem with antigen testing, of course, is that lots of people want to roll it out as a sort of a screening tool, in which case, I suppose at 11 o'clock at night in Queensland, a chat about pre-test probability and its role in sensitivity and specificity is not it's not what anyone wants. But the idea that lots and lots of asymptomatic people can be screened using rapid antigen tests, and you not get a buckload of work for your public health units in either false positives or false negatives, trying to dig through them to get the real ones. It's not realistic, especially as your community incidence gets low. So what the question may have been about is in sort of high risk settings, managing outbreaks, we don't need them because we have access to PCR testing, which is much more much more reliable. I know there have been some sort of people wondering about the reliability of PCR testing and about prolonged shedding, but I can reassure people, without wanting to go into the sort of details of it, that public health doctors and infectious disease doctors are able to work out by talking to people and by examining them whether their positive PCR test is likely to be the result of current illness or past illness. So we've been very happy with our rapid PCR testing and our non-rapid PCR testing. So yeah, no need for rapid testing just yet in Australia, but I think the technology will improve and may well become suitable for testing larger swathes of the population. Watch this space, I reckon.
Great, thanks, Niall. So I think the last sort of two questions actually both touch on the same thing, which is around travel, and I suppose goes back to your emphasis on mandatory quarantine. And one was around whether people can come and visit at Christmas. And then the other one, which is around kind of international business, and I think is maybe helpful for us working in Europe, is whether the same sort of very rapid, frequent travel exists within Australia, and I'm thinking even within states, and then also outside of Australia. The question was around whether international businesses are flying sort of in and out of different places every day, as would be the norm in Ireland, with the US, the UK, and across Europe.
Yeah, I mean, look, I suppose what you've got is a situation where Australia is more analogous to the EU. It's about that size, and you have 8 different states of which you have to fly to get to them, and there's enormous amounts of internal travel amongst the states, and we've managed to keep COVID from spreading between the different states. Sydney, Melbourne, Brisbane are some of the busiest airports in the world. I do take the point that people make a lot about how sort of how integrated Europe is and how Ireland relies on travel, but Australia is enormously reliant on travel, and you just need to look at, like, from a public health perspective. When I worked in Brisbane, we used to cover the airport, and just looking at the amount of flights that used to come in on our schedule that we used to be given, like, there is enormous traffic. Whether it's more or less than Munich or Paris, I don't know, but I mean, there is an absolute shed load of people arriving into Australia every day, and of course their trips are not as quick coming to Australia, but certainly across Australia they are, from Brisbane to Melbourne, and Sydney, and that's the equivalent of your European travel. That's your 1 or 2 hour or 3 hour or 4 hour flight that business people do all the time. And but there is a lot of travel. We're heavily reliant on tourism. No matter what anybody says, we are extraordinarily reliant on overseas university students. The university sector is one of our biggest industries, and we can't have them at the minute. Like, it's been an absolute sledgehammer to the university sector in that respect. What people don't realize is everybody listening to this will know some young people have gone backpacking around Australia and done some fruit picking. Our entire fruit picking industry, which is a multi-billion-dollar industry is reliant on backpackers coming and doing fruit picking, and the fruit isn't getting picked. And I think, not that I don't mean it's the implication of those questions, but often the questions I get asked, or the points people make to me, are essentially sort of saying, this is really easy for Australia and New Zealand, this is a really easy thing to do. It is not. It was absolutely, an enormous undertaking. The idea that a country like Australia, like I would look at it a bit differently. People say Australia is so isolated, so it's easy for you not to have people. I think it's the opposite. I think when you're such an isolated country, you're so dependent on travel from your neighbours. You're so dependent on tourism from outside the country. You're so dependent on, our workforce, like the economy and its reliance on just the international workforce in Australia. Like, there's an enormous reliance on people coming in from overseas. It's been really difficult. The idea that it's been easy to close our borders is something that's been mooted to me as well, which is absolutely crazy. Our borders are thousands of kilometers long and they're incredibly porous. It's been such a challenge that the army have got involved in policing them and the whole lot. It's been a very, very big challenge for Australia. Like, this idea that it couldn't be done in Europe, it's really easy in Australia. It is not. Anyone who lives here will tell you it has been an enormous challenge. And when it was all happening, and when we had cases along with all these border controls, and we had lockdown and border controls, it was so hard because people couldn't see the light at the end of the tunnel. But now they can. And I don't think there's anybody in Australia looking over Europe and saying, I think we should be more like them. I think we should have open borders. It was hard though. It was very, very hard, I have to say, but it's a lot better now.
Thanks, Niall, and thanks so much for giving us all a bit of light at the end of the tunnel. I think that was just a fantastic exposition of what's happened in Australia and the huge efforts that have been done. And it's really important, I think, for us to hear that and know as well that it won't be easy, but that at least we can start the conversations about whether this is an approach that we could take here in Ireland. So I am very conscious that there's still some more, I think, questions coming in, hopefully mainly just people saying well done and thank you. I know it's late at night there. So just want to thank you again for giving us your time, and thanks everybody for contributing. And we will be putting this up on our YouTube channel as well and disseminating it further. So thanks so much.
No, thank you. And thanks to those who stayed to listen to me.
Everybody stayed right to the end. So well done. Thanks so much.
You're very welcome. Thank you.
Bye now.